we would, Dr. Srinivas,
Yes, madam.
you can screen share, and Dr. Lalit, we would be obliged if you could moderate this debate. Dr. Lalit, you're still connected?
I think Dr. Anand or Dr. Shobit can do that if Lalit.
Yes, Dr. Shobit, you could moderate this debate.
No problem.
Yes, thank you.
Okay. Thank you, Chitra madam and team ARC for this opportunity. So let me start ahead with what Dr. Purna said. See, these are the advantages in the. I think there's some background noise. Yeah. There are various advances in the visualization system. This is how we started the bare eye surgeries, you can see there. And then we went on ahead with the microscope based surgeries. Now we are in the monitor based surgeries, and the future is going to be the heads free visualization, which Dr. Purna doesn't want to move ahead with. So what are the advances in display resolution? We had standard definition before, then we came into the enhanced definition, we came into the high definition, and now we are into the 4K. I would like to ask, what kind of TV does Purna Chandra have it? So coming to the surgical ergonomics, the physical impact, by the age of 55, over 70% of ophthalmologists have neck or back pain. It's not said by me, by the Art Journal of Ophthalmology. And this is how is the picture. You have to sit straight, strain your neck, strain your back. I do not disagree. It's not a bad technique, but definitely when things are there for comfort, then why go to the old school of thought again? You can see the assisting surgeon there, and you can sometimes, if the microscope is not, the observer scope is not very well aligned, this is how our poor fellows have to definitely assist us. And this is not my picture. This is just taken from Dr. Purna Chandra's presentation. You can see this operating surgeon, how they are clutching their shoulders there and how uncomfortably they are trying to see through the microscope. And here comes the comfort. See, what's important for the operating surgeon? The comfort. They have to be in the comfort zone so that to give the optimum results for their complex cases. So there you have a good lumbar support. It's an excellent teaching tool. You can show it to different fellows, your residents, your observers at the same time. But the only misnomer here is if you have a very small mistake, that appears big on the big screen. And the most important, we try to do this. I'm talking with facts. We try to do this with the DNB students and the SICS trainees, trying to have that. The trainer, you can see that it's nothing like a modified blackboard teaching. Here, they can just move it on the screen. They can show it where you have to make the incision, where you have to make the tunnel, how to do the rexus, how to move it here, how to move it there. See, it's nothing but just a modified blackboard. It's nothing but, I would like to say, a glorified blackboard teaching, which we all evolved through. And definitely, it has one of the best visualization. Every detail of the step can be explained simultaneously while operating, can be taught to many people at the same time. The various studies, which I think Purna showed few of them, comparison of 2D and 3D video displays for teaching vitreoretinal surgery, which again says that it definitely has an efficiency. The scope of three-dimensional digital visualization system in vitreoretinal surgery, published in Clinical Ophthalmological Journal in 2019. Again, it says that definitely it has a good effect without compromising surgical viewing or increasing surgical complication. We have another randomized control trial done by our own Indian ophthalmology by Dr. Atul Kumar sir, comparison of clinical outcome between heads-up 3D, a pilot surgery. Again, he said that definitely it's not inferior. And in fact, it had an advantages of better ergonomics, reduced phototoxicity, peripheral visualization, magnification, and less asthenopia. So again, recently published in Ophthalmologica, comparison heads-up versus binocular microscope. Definitely, it showed that it improves the operative fluency and allows for the faster penetrating keratoplasty surgeries. So when we look into this national survey of back and neck pain amongst the consultant ophthalmologists in UK, they said that 62% of the people presented with a back pain and 33% of the ophthalmologists with a neck pain, and operating on whom 78% found operating exacerbated their pain while doing the surgeries. So utility of three-dimensional surgeries, not only in VR, but also in cataract, minimally invasive glaucoma surgeries. Definitely, the papers have shown very, very encouraging results. Let me share my own cases. Apart from magnification, depth perception, and all those things which have already been evolved, the special feature which I found out is slightly increase in the peripheral acuity. Here you can see this is the conventional viewing. Now let's go into how the 3D looks like. Let's share this video. This was a tile cutter. I have presented this in the last VRSI conference as well. This is the tile cutter where a large chunk of the blade of the tile cutting machine actually went into his eye and it halved his eye. And in the emergency clinic at 12 o'clock, our cornea fellow did a meticulous job. Now I took it for surgery after 7 days. There was no target inside. You could see there's a large sutures in the center. So initially it was very difficult for me to have a visualization. Definitely, as I tried to peep through one part of the cornea, I could get a better visualization. Initially, I was not knowing what I was cutting, whether it was the vitreous, it was the altered vitreous hemorrhage or the retina. But definitely, after dissecting each plane, I could definitely induce a PVD in this case. And I could see some good amount of viable retina left over. That's how it gave me a confidence. But definitely, it was troubling me in between because there was a lot of traction. I had to do a retinectomy, try to drain the subretinal hemorrhage in these cases. And finally, after putting the PFO, you can see the laser marks here. Fantastically, you can see the retina. And this is how in the small one half you could visualize, which was definitely very difficult with the microscope. These are the various cases which we have operated upon, and these are various things which we have studied, which we are still undergoing more than 200 cases regarding on high magnification performance, depth of field, image enhancement, visualization under air, in hazy media, in restricted field, surgeon's comfort, surgeon satisfaction, assistant surgeon trainee. So all these things you can see here, the blue tick, the blue bar, which showing the Ingenuity has shown a slightly advantageous, including the surgeon's comfort, surgeon satisfaction. So what's going to the future? Sony HMS 3000 MP, which is going to be totally heads-free. So this is the diffusion of innovation theory, which is described by Everett Rogers. He says that there are only 2.5 to 13.5% who are actual innovators and adopters who try to pick up the latest technology, and 16% of the laggards. That is, when the technology become obsolete, then they hop in for the new technology. So let's say you have embarked a long journey. What would be your choice for a ride, Dr. Purna? Would you not like to have a car with the safety features, with the seat belt, with the airbags and everything? Definitely, you would like to go in for the anti-lock, electronic stability and all those things. Or would you still prefer the age-old technology ambassador? Definitely, mind you that it has served us well in the past, but it's not catching up with the technology that can be devastating or wrongdoing. This last slide I want to say about the Nokia, which is very well evident. He said, the CEO, Nokia CEO said, we didn't do anything wrong, but somehow we lost. When the analysts looked into it, they said that they missed out on learning, they missed out on changing, they lost their chance of survival. So message of the story is, if we don't change, then we shall be removed from the competition. As Purna said, old may be gold, but Purna, please remember, new can always be platinum. We can't stop aging, Purna, but we can always choose how to age. Thank you very much for the patient listening. I would like to acknowledge Department of Vitro-Retina and Dr. Giriraj Vibhute for helping me. Thank you very much.
Interesting debate. A brief word from you, Dr. Shobhit, before we move on to our last speaker. I think we are really late today.
Chitra, both Dr. Srinivas and Dr. Purna Chandra have done a fantastic job. Yes. Now, I will put my point forward. After having, it may be disheartening to Srinivas, but after having used 3D systems, I still enjoy using the wide field on the conventional microscope because of 3 reasons. I find in my hands the depth is better. The last case where he showed that the cornea was halved into 2 and had sutures, I think a good wide angle non-contact viewing system can give an equally good. And all the papers he cited showed equivalence, not superiority, of using the 3D systems. And my last point is that the cost implications, and I feel it might be good for the back of the surgeon and the lower back and the neck to some extent, but twisting the neck to one side is also not a very comfortable feature in the present generation. Yes, I look forward to what he showed in the end, the Sony system, which will be based on virtual reality. I do look forward. Thank you very much.
One small comment I wanted to make, Chitra, if you allow, that you mean in surgery, there's noise coming up actually.
There's a lot of noise.
Need to mute.
Okay. I'll shout from here. In surgery, you tend to do better if you see better. And you see better if you are magnified better. Forget about back pain, Sony, all those fancy toys which both Purna as well as Srinivas tried to prove their point. But you see, you have to magnify to PL and ILM and to avoid all complications. Seeing thereby technology advancement, you have to catch up.
Ma'am, since
Thank
Dr.
you very
Srinivas
much,
asked
Dr.
me
Lalit.
many,
And
yeah, ma'am. Since Dr.
Purna,
Srinivas
sorry,
asked,
there is no chance for rebuttal.
Even though
No,
I
no,
don't,
no.
even though I don't have it, even though I don't have it, but there can be no. I have seen, this place. There can be no better teaching tool than this 3D technology.
No, it's of course a good teaching tool,
Yeah.
but you use
Yeah.
it one, Lalit.
Yeah,
And
I'll
then-
just add a small point. I've been using Ingenuity throughout in the last 2.5 years. It's great. It's like watching your 42-inch TV, and then after that, going back to a box TV would be the kind of equivalence if I were to match and compare.
Addiction.
But what I'd like to say is that I would like to say, yeah, I would like to say is that I would not like to strongly push the envelope saying that equities are better in the hands of those who have an Ingenuity system than those who do not have an Ingenuity or a different system. So it's great once you have it and you learn. It takes a little while to get adapted to, as I also did, and we learn to give great outcomes. But I would not like to discourage or put down people who do not have it, and to say that it can still people.
thank you very much, Dr. Anand.